Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abbie Ross and Dr. Danielle Tolman.
Welcome back, everyone. This is Talk Dizzy to Me with Danny and Abbie. Today we have a special guest, actually, a patient referred Dr. Gianoli to us, and we're so excited to talk about all things third mobile window. Dr. Gianoli, thank you for joining us. Can you give our audience a bit of an introduction on how you got into this world of vestibular everything?
Yes, that's very interesting, actually. I finished my fellowship in neuro-otology and skull-base surgery in 1995. And that particular year, my mentor was the president of the American Neurotology Society, and he automatically throws me on this committee for the ANS that was the Balance and Equilibrium Committee. And I felt wholly inadequate to be on that committee because I thought that was my weakest part of my education was on vestibular. And so I entered this meeting, and around me are about 8 guys who are like the giants in the world of vestibular medicine. And they're talking. I'm just trying to fade into the background while they say, okay, well, who's going to run this vestibular course that we're going to course to teach all the docs how to do vestibular testing? Oh, hey, you new guy, you do it. So that was my introduction. I got thrown in headfirst into the deep end of the pool, and I wound up running the course for about 5 years. And that's really was my introduction to vestibular medicine. Now it's about 95% of my practice.
I feel like that is a tale as old as time. You know, you get thrown into joining some sort of organization or committee, and then really they had you join so that you could take the front and lead on something. So that's actually quite funny. Danny and I are both familiar with that. But anyway, we're here to talk today about third mobile window syndrome, defects, symptoms, diagnoses. Can you explain the difference between those terms?
Certainly. So when you look at the anatomy of the inner ear, you've got the entire inner ear is encased in solid bone, and there's really only 2 sort of weak spots, the round and the oval window, and they separate the inner ear from the middle ear. The oval window is just a thin membrane. It's just a couple layers thick. And then you've got the oval window, which is where the stapes, or the last hearing bone, sits. And there's a ligament around it that allows the ear bone to move up and down and send sound transmissions into the inner ear. Well, the reason for that round window is to shunt the sound pressure to the cochlea so it doesn't go to the balance organs. Okay. So there's 2 normal mobile windows. In third mobile window syndrome, there's a defect somewhere else. And what happens is it screws up the fluid mechanics of the inner ear, and you wind up getting sound pressure shunted to another part of the inner ear that it's not supposed to go to, particularly the vestibular part. And you get vestibular symptoms. And one of the hallmark or most characteristic symptoms of third mobile window syndrome is sound-induced vertigo and dizziness. And it's because sound is coming in, instead of getting shunted to the cochlea, it's some of that sound pressure is getting shunted to the balance organ, and it's stimulating it abnormally. There's other symptoms you can get from that. You can get intracranial pressure changes will kind of push the pressure the other way. Like if they strain hard, a lot of these folks will also hear their heartbeat in their head. They'll have pulsatile tinnitus, that sort of thing. Right off the bat, we probably should kind of make some definitions. First of all, there's the word syndrome. Okay, a lot of people think of that as being a diagnosis. It's not a diagnosis. Syndrome is basically, it means a collection of symptoms that are frequently seen together. And in third mobile window syndrome, the more characteristic symptoms you'll see are pulsatile tinnitus, strain-induced dizziness, sound-induced dizziness. You can also see something we call autophony or conductive hyperacusis, where you hear internal sounds more loudly than you would normally, like your voice sounds louder and it sounds distorted, or you hear your eyes blink, or crazy things like that, that a lot of times the patients are afraid to tell the doctor because they're afraid of being called crazy. or they think it's unrelated or what have you. So it's something the clinician really should ask the patient. So that's the symptoms that you see with the syndrome. If you have those symptoms, you have third mobile window syndrome, regardless of what your diagnosis is. Second, if you've got an anatomy that has a defect, such as a superior canal dehiscence, a hole in part of the bounce system of the inner ear, you have a third mobile window defect. Okay. Now, the interesting thing about it is not all patients with the defect will have the symptoms or syndrome. Mm-hmm. As a matter of fact, probably most patients with third mobile window defects were born with them, and they did not have any symptoms until later on in life. So those patients don't have the syndrome, but they have the anatomic defect. And then there's third mobile window disorder, where they have the defect, they have the symptoms, and they've got the diagnosis.
Is there a reason for the symptoms showing up later in life, or is that just part of the game?
Right. So that's a somewhat controversial in the literature. What is not controversial, however, is the observation that a lot of these patients will have onset of symptoms after a second event. As I mentioned, most of these patients have probably had the defect since early childhood, and then something happens later in life. The majority of the time, it's head trauma, some major pressure altering events, and by that I mean, think of a mother who is having her first child and has a very prolonged vaginal delivery. They'll say, "Oh my goodness, I've had this ever since the delivery," and they'll blame it on their firstborn. Barotrauma, flying in a plane, scuba diving, think weightlifter, really straining on the bench press, vigorous nose blowing. Believe it or not, when you blow your nose vigorously, you will double intracranial pressure, and that pressure gets transmitted through that defect. So we're thinking of someone who's got an anatomic predisposition that then has an event that later provokes things. Another observation we've made is that there's a subset of these folks that probably over the course of their life, they slowly developed increasing intracranial pressure that also predisposed them to where that second event becomes lesser and lesser of an issue, that, even just a cough could eventually tip them over. If you look at fetuses in utero, 70% will have a superior canal dehiscence. By the time they are born, it's about 10%. But then by the bone on the middle fossa floor or above the middle ear and mastoid gradually thickens during the first 4 years of life, to where by the time they're about 4 years old, it's around 1% will have a dehiscence. The bone in that area continues to thicken basically up until, adolescence or so. And then it gradually thins throughout the rest of our life, very, very slowly. So, there are a lot of children you can get a scan on, you can find they have a dehiscence. And I'll never forget one of my first patients, this is probably back in 1999, 2000. I had a young girl, she was about 8 years old. She had a congenital cholesteatoma in her ear, and I scanned her, and on the opposite side, she had a superior canal dehiscence. And I asked the parents, does she have any problems with vertigo, dizziness, anything like that? Oh, no, nothing like that. And I said, well, she's got this anatomic problem that, would predispose her to have problems. So I do her surgery. She does great. I don't see him again. 10 years later, she shows up. Now she's like 19. She shows up on my office saying, well, you said one day I would be dizzy. Now I'm dizzy.
Now, is there any chance that patients can be walking around with a superior canal dehiscence or a third window syndrome and never have symptoms and never present with issues and just kind of be found incidentally?
Well, let me correct your verbiage there. Yeah. Syndrome means they have symptoms.
Correct. Yes.
So the question you wanted to ask was, do they have an anatomic defect and not have symptoms? Absolutely. So a classic sort of scenario for these folks is they are completely fine. No balance, dizziness problems, no autophony, no pulsatile tinnitus. Then they get in a car accident.
Mm-hmm.
And then sometime shortly thereafter, they start having all the symptoms. Now, those folks, I guarantee you their anatomy was the same. You know, they're not having temporal bone fractures. Now, not all cases of superior canal dehiscence or other third mobile window disorders are congenital. I have seen some that are acquired, that I know for sure are acquired. I've seen cases where arachnoid granulations have eroded into the superior canal, cholesteatoma, meningiomas. I think these are much less common cases. I had one where the bone was relatively thin and he had a head injury and it cracked across that area. And you couldn't see it on the scan. It was only at the time of surgery you could actually see the fracture because it was so tiny. But you know, he had all the symptoms and all the syndrome, if you would. So there are some that are acquired. And as we mentioned, the bone thins out throughout the course of our life to where there are probably some folks that have very thin bone and it eventually kind of fades away and they become symptomatic.
I imagine that after an event that might bring on symptoms like a car accident, those patients might be very quickly misdiagnosed with something else like post-concussive symptoms or something along those lines rather than identifying the defect. Is that the case for some people?
Absolutely. I have a whole talk geared toward just that question. You know, the number 2 symptom for concussion is dizziness, and it's rated to be about 80% of post-concussive patients have dizziness. The interesting thing too is there's a thing called vestibular agnosia, where patients, and agnosia is really more of a neurology diagnosis, where the patients have sensations that their brain ignores or doesn't recognize. And you see this more with the moderate and the severe TBI patients than you do with the concussion patients. But if you look at moderate and severe TBI patients, a lot of them, like I'm talking about 90%, will have balance issues that they don't recognize. There was an interesting study, just look strictly at BPPV, and you know, where like say 100 patients had positive Hallpike tests, only 10 even recognized that they were dizzy when they were having nystagmus, and that's vestibular agnosia, and they would fall and such. You don't as much concussion patients, but the other thing is there's several other symptoms that you see with post-concussion that can be attributable to the ear. In particular, brain fog is something that everybody wants to blame the brain for, and it could be, but it's well known that vestibular problems cause brain fog, and there's some good studies on that as well. The other one is anxiety and panic attacks. You know, they talk about post-traumatic stress disorder, and that does exist, but when you stimulate the vestibular system, one of the reflexes is to the sympathetic division of the autonomic nervous system, which number 1 causes nausea, sweats, increased heart rate, increased blood pressure, and it causes the adrenal glands to dump out adrenaline, which can cause anywhere from anxiety to frank panic attacks. And unfortunately, a lot of these folks get sent to the psychiatrist thinking that they're just crazy. And what they have is a chemical phenomenon. As a matter of fact, if you look at the DSM-5, which is the psychiatrist's Bible for diagnoses, and you look up panic attack, there are 13 different characteristics that you need to look at. You need to have 4 of those to be able to diagnose a panic attack. 8 or 9 of them happen routinely with a vertigo spell. Now, at the bottom, it's written in small print, first must exclude a pharmacologic effect, as in they're not mainlining cocaine, which will do that as well, or a physiologic process, such as a vertigo spell. But the problem is they can't see the vertigo spell, and often the vertigo spell is gone by the time they're having the panic attack.
Wow, so interesting. I feel like we can take this discussion in so many directions. As an aside, I wanted to say in my first job, I worked in a primarily just concussion clinic. And it always baffled me, these patients that would come, they'd have all these symptoms, but they wouldn't report the typical room spinning sensation that is associated with BPPV. But sure enough, test for BPPV, treat them, and then all of a sudden, all these other symptoms dissipated. It was like magic, and they thought I was a magician. It was great. Uh, but can we talk more about the various diagnoses that fall under this? Maybe define them each. What are we looking at with each of them?
Sure. So all of them, it's basically any defect somewhere in the bone around the inner ear can do this. And the one that's most recognized is superior semicircular canal dehiscence, but it's actually probably not the most common one. Probably the most common one is cochlear facial dehiscence. And that's where the facial nerve goes over the cochlea. And it, again, can produce a very similar set of symptoms as superior canal dehiscence. I don't think it's as critical of a lesion as superior canal dehiscence because the pressure differential is probably not the same as you get with superior canal dehiscence. But you can also see a defect of probably the second most common after that is posterior canal dehiscence, which is very similar, except it's a different part of the anatomy. It goes to the posterior fossa as opposed to the middle fossa. You can see horizontal canal dehiscence where the facial nerve goes over the horizontal canal. That's something we reported about 2 years ago. That's probably a whole lot more common than we realize. It's just a hard place to be sure there's a dehiscence because there's very thin bone there to begin with. Which then leads to the whole issue of near dehiscence, which, so for example, a patient comes in, they get a scan, they say, oh, there's bone there. Well, the problem with bone is it's like wood. When it's thick, it's nice and solid, but when it's thin, it can be like a sheet of paper. And it can have the same properties as a sheet of paper. And I can tell you, as a surgeon who's done more than 600 superior canal dehiscence cases, you can get in there and find pieces of bone where you can just push it and it moves like a piece of paper. That's how thin it can be. So, in those patients, even though they have bone, it can functionally be like they have no bone at all. And we've even been able to kind of define what's the cutoff for where is too thin to be, to the point where it's critical. And in general, 0.4 millimeters or less is when you really got to be suspicious of that area. And just to give the audience an idea, 0.4 millimeters is about two sheets of paper put together.
Wow. So in these patients that come to see you, what are you listening for in their history specifically that clues you into this maybe being part of their problem?
Sure. So we mentioned, the sound-induced dizziness. That's a big one. And you want to make sure it's not sound-induced discomfort, which is hyperacusis. Now, you can also get that with third mobile window syndrome, but I find it's not as highly linked to third mobile window disorders as sound-induced dizziness. And very often I find if I ask a patient, does sound make you dizzy? They'll say, oh my goodness, yeah, I heard it really bothers me. And it's like, no, that's not what I asked. I asked, does it make you dizzy? And then you get a different answer. So you got to be really particular when you're asking patients those questions. Strain-induced dizziness is a big one. And, the most common being nose blowing, straining to pick up something heavy, coughing, straining to have a bowel movement, which is something patients generally won't tell you about unless you ask, those sort of things. And then on the auditory side, we talked about the autophony, hearing your voice abnormally loud, the conductive hyperacusis, where you hear internal sounds loudly, the pulsatile tinnitus, hearing your eyes blink, Very frequently, they have a lot of other symptoms that are less specific to third mobile window syndrome. For example, pressure in the ear, real common. Tinnitus in general, we talked about pulsatile tinnitus, but they can also have tinnitus from having damaged their ears and having sensory neural loss. That's not unusual. Fluctuating hearing loss, you can see. Another vestibular symptom, and some of this I think goes to what Abbie was talking about earlier, where these folks have these non-specific, not spinning episodes. Well, they'll report rocking, feeling like they're on a boat, very similar to mal d'embarquement descriptions. And what they're seeing is they're seeing their gravity sensors get pushed back and forth with every heartbeat. And when you lower that pressure or you fix the superior canal dehiscence, that goes away. So, among the symptoms, that's probably the most common that we see.
With a lot of those symptoms, it seems like you can now do some things in order to test that out objectively. What does your examination look like for testing for these types of issues?
Sure. For, as far as the physical exam, there's not a lot of new great stuff for that. They'll if they've had enough time with it or enough damage to their inner ear, they'll show signs on the physical exam of having some inner ear damage, but that's non-specific. It doesn't tell you that they've got a superior canal dehiscence or what have you. For the more specific diagnosis, that's when you need, vestibular testing and imaging.
Hey guys, it's Abbie here. Unclench your jaw, relax your shoulders, take a nice deep breath. Doesn't that feel better? Thank you so much for listening to Talk Dizzy to Me. One of our missions here at Balancing Act Rehab is to spread awareness about vestibular dysfunction, and the best way to do that is with your help. We'd be so grateful if you took a moment to subscribe, review, and share our show with someone you think would benefit from hearing our conversations. Let's get back to it.
I want to get into the testing and the examination bedside as well. But first, can you touch on, I guess I imagine, because in general, the vestibular community often sees several providers before they get to the right one and the right diagnosis and the right plan of care. How often are you hearing that in your office, that patients are seeing multiple providers before actually being diagnosed with what is actually happening with them?
Sure. Well, I have kind of a unique practice in that I'm not contracted with any insurance companies. I'm strictly a cash-based practice and have been since 2005. So I don't see people right out the box generally. Probably my average patient has been dizzy for 4+ years, and they've seen, you name it, they've seen them in multiple providers. Usually, of course, primary care, they've been to several neurologists, several ENT doctors, other neurotologists before they want to come in to see me. And my practice has become one where, specifically for superior canal dehiscence and third mobile window syndrome, if there's any question about it, I wind up drawing them from all over the place.
So now let's get into when these patients come to your office, you do your thorough history. What specifically is in your bedside exam? And then how are you determining what diagnostic test to order from there?
Sure. So again, because these patients have been dizzy for so long, they've not found relief. I do an extremely thorough exam. And in fact, if they're not ready for that, they're probably not ready to come see me. So I don't hold back on the testing. But as far as the physical exam, I do a full ENT exam where we look at the ears with a microscope. There are some folks that have had like a cholesteatoma. Actually, I had one last week that had burrowed into his inner ear, and it was part of the source for his third mobile window syndrome. And that's an easy diagnosis to make, but unfortunately, that does get missed periodically. So that's one of the things you have to make sure you look at their ears. Then we do an eye exam, make sure they have good ocular motor function. They don't have, strabismus, that sort of thing. And it's surprising to me how many patients do have strabismus, at least to some mild degree. And then we do a video exam. We look at spontaneous nystagmus. We look at head shake nystagmus, head thrust, that sort of thing. Do a cerebellar exam. And that's pretty much it. Now, for all of that, in somebody with third mobile window syndrome, usually the only things you're going to find are, as we mentioned, the abnormalities on the history. As far as the physical exam, there's often a little bit of an asymmetry between the ears, sometimes a lot. And you'll see some findings suggestive of that, a spontaneous nystagmus or a head shake nystagmus, that sort of thing. You'll see abnormalities on the Fukuda test, which was always kind of fun for patients. For those not familiar, the Fukuda test is where you have the patient close their eyes and march in place. And the normal result is either to stay still or kind of slowly move forward. If you've got a significant vestibular asymmetry that the brain has not adjusted for, they will slowly rotate to the side of the deficit. It's not a 100% test. Obviously, if someone's got a problem with their knee or ankle, it's going to screw things up. But it's always kind of fun when it happens, and it's kind of fun to see the patient's response when they've turned all the way over to the left side, and they're like, "Oh my goodness, how did I get here?" That sort of thing. But that's about it on the bedside exam.
Do you replicate any of the pressure tests?
I don't in the office. I do that in the VNG lab. And the reason for that is I get a much better image of the eyes. I can see subtle movements of the eyes, as opposed to, I do have a video system in the office, but the eye's about this big. In the VNG lab, it's about this big. And you can see little subtle movements that you wouldn't see with the smaller one. The other thing too, we record the videos in the VNG lab, so I can go back and look at them later, that sort of thing. Which brings up a good point. As far as testing goes, a lot of my fellow clinicians and patients are under the false impression that the vestibular evoked myogenic potential test is the all to end all to diagnose superior canal dehiscence and third mobile window syndrome, and it's not. First of all, vestibular evoked myogenic potentials is a test of the otoliths. It's not a test of the superior canal. It is a test of the utricle and the saccule. Those are the two gravity sensors. The saccule basically sends most of its information to the postural muscles. The utricle sends most of its information to the eye muscles. And so with O-vemp, ocular vemp, and C-vemp, cervical vemp, which is the saccule, we can look, it's one of the ways we can look at otolithic function. And it's frequently abnormal in inner ear disorders. For example, if you have someone who has had, let's say, vestibular neuritis, and it's destroyed their ear, well, you will see those vemp responses go away. They'll have an absence of it. In a classic superior canal dehiscence patient, you will see an increase in the response. And it's mainly because there's a lot more sound being shunted to the area the saccule and the utricle is located, but it's not a superior canal dehiscence test. Now, let me give you an example where this fails. First of all, the amount of sound being shunted is directly proportional to the size of the dehiscence. So in other words, you get a big dehiscence, you're gonna have a lot of pressure shunted there. Little tiny dehiscence, not so much. And those patients can be still just as symptomatic from a vestibular standpoint. I had one patient a while back who was initially diagnosed with superior canal dehiscence and had normal response on caloric testing in the ear, the hot and cold water, which kind of tells you how well the semicircular canal function is, but had an abnormally responsive vemp test. And so they did a CT scan. It showed she had a superior canal dehiscence. And it was pretty much like most of my colleagues are talking about now. Well, she decided not to do any surgery or anything about it. And then 5 years later, she had repeat testing. And what they found was the vestibular myogenic potential test, the VEMP test, was less responsive. And the caloric test showed a deficit on that side, suggesting there had been progressive damage over those 5 years. Well, then she shows up in my office 10 years after the original diagnosis, and we do our testing. And what we find is her VEMP is now, quote unquote, normal, but her caloric test shows a severe deficit. So what has happened in that particular patient is over those 10 years, she's had progressive damage to her inner ear to where her utricle and her saccule is not responding as near as well as they were 10 years ago. And if you use the VEMP criteria as the diagnosis, you would say, oh, no, she doesn't have superior canal dehiscence because her VEMP's normal. And the reality is it is abnormal in that context. Now, in my mind, when you're looking at these folks, you have to not just look at their history and VEMP testing, but there's a whole bunch of pressure tests you can do. And as you mentioned, the fistula test or Henneberg test is one of those. The whole idea of that, you're putting pressure in the ear canals, putting pressure on the eardrum, the ear bones into the inner ear. If you've got a weak spot in the ear, like a superior canal dehiscence, it's going to tend to stimulate the inner ear and make the eyes move. And you can see that on testing. The patient will also often say they feel like they're being rocked back and forth with the test. You can also do Valsalva testing. I'll have them do nasal Valsalva, where it's 1, 2, 3, take a deep breath, hold your nose and blow, and you're putting pressure from the inside out. And then glottic Valsalva testing, where they hold their breath in their throat and they strain with their belly and chest. Frankly, of all of those, the one I find is the most sensitive is probably the nasal Valsalva test, even more so than the VEMP test. There's one other test that I use that I don't think anybody has left, is the platform pressure test. And it's because they don't make it anymore. And I have one that's from eons ago. And it's looking at basically the fistula test, except looking at the vestibulospinal reflex. And it's a different way of looking at that, increased compliance to the system. And it's a test that I find it's not very sensitive, but it tends to be very specific. If it's abnormal, they've got something going on there. But if it's normal, it's not real helpful.
Well, one of the things that patients or patient audience always likes to hear about is, what do I do about this? So can we get into the management and treatment options available?
Certainly. So, the first thing is, in the patient that has minimal or no symptoms, you really don't need to do anything. Sometimes in patients that are just concerned, oh my God, do I have a tumor, or that kind of thing, reassurance is often all you need. Now, when we get to those who are symptomatic, if you look through the literature and you talk to most of my colleagues, they're going to tell you the only option is surgery. And that is something I totally disagree with. I have been treating patients medically for probably 15, 20 years, and I've gotten really good results with medical management. And the first article I have yet to see specifically on medical management came out just last month. And it was from a Spanish group that pretty much mirrors my experience. They reported 60, 70% significant reduction in symptoms with medical management. Surgery, the success with surgery, and one thing I find you have to discuss with patients is there's a whole variety of symptoms. Certain symptoms are better with certain treatments, but not all symptoms. For example, tinnitus, I find, is one of those symptoms, you don't want to ever promise a patient that they can get their tinnitus will get better no matter what you do. I've had patients who referred to me with superior canal dehiscence, and their only symptom was tinnitus. And what I tell them is it's not reliably improved with anything we do. If we do surgery, my experience with surgery is, and this is not that I'm doing this for tinnitus, but what I find is if you talk to these folks, about a third of them, their tinnitus is better. About a third, it's the same. and about a third, it's worse. So with those odds, I would not do surgery for tinnitus. You're talking about 2/3 or a failure, if you would. Now, if you're talking about vestibular symptoms, totally different story. 95+% get improvement or resolution of their vestibular symptoms with surgery. Now, we talked about medical therapy. What do we do for medical therapy? Okay, so the thing to keep in mind with this is a pressure problem. And the way to improve this medically is to reduce that pressure differential. So if you've got someone who has high intracranial pressure, you want to lower it. If you've got somebody who's got normal intracranial pressure, it doesn't hurt to lower that as well. You also want to prevent spikes in the pressure. So the first thing I tell them, stop straining. If you're doing yoga, Pilates, weightlifting, stop it, because that's going to make things worse. My partner used to joke, thank goodness for yoga and Pilates because they send us so many patients. So that's the first thing. And, a lot of times patients don't realize that. A fair number of them do, and they start kind of self-correcting their behavior. So first, I call that fistula precautions because it dates back to when patients were diagnosed with perineal fistula. They were told, don't blow your nose, don't strain, etc. Second is their dietary precautions I would have them make. Avoidance of salt. Wherever salt goes, it drags in more fluid. The more fluid, the more pressure. So it makes sense to kind of limit salt intake. Caffeine dilates the blood vessels going to the head, which increases the pressure. And so I have them reduce their caffeine or eliminate their caffeine intake. Third thing is, I think, a little bit more specific. There are some folks that are very sensitive to certain foods that will cause migraine type symptoms. And for those folks, it's kind of the same thing as caffeine. They get a dilation of the blood vessels, increased pressure, and it makes the symptoms worse. So those are the three things with diet: salt, caffeine, and avoidance of migraine triggers if they apply to you. The last is medical therapy. And there's a number of different medications you can use, but the whole idea being lowering the pressure inside the head. My favorite medication to use is acetazolamide, which is the classic medication for lowering intracranial pressure. And that works about 60 to 70% of folks do extremely well with that. And probably the cardinal symptom I look at to give me an idea whether we're heading in the right direction is whether they have fullness or pressure in the ear. When they tell me I've eliminated their fullness and pressure, I almost don't even care what the other symptoms are because they're going to get better. For example, very often you'll see somebody, they come in, they've got a superior canal dehiscence, but they've also got an uncompensated vestibular loss on that side. And there's a whole lot of symptoms, as you know, from an uncompensated vestibular loss. And they've been through physical therapy. They've not had responses from it. And it's like, why are they not compensating after 5-6 years? And one of the reasons is because they've got this fluctuating vestibular disorder that keeps banging on their inner ear and causing more damage. Well, the first step is stop the damage. Once you get them stable, then suddenly physical therapy works wonders, and they can start compensating for their vestibular loss. So, when let's say I talk to them, 3 weeks after we start medical therapy, a typical scenario I'll hear from the patients, first I'll say, well, how are you doing? And they'll say, oh, it's awful, doctor. I'm still very dizzy. And I'm like, well, let's kind of go through your symptoms. First of all, do you have that fullness and pressure in your ear? And a lot of times things get real quiet and they say, oh, now that you mentioned it, it's gone now. Okay, all right. Do you have that heartbeat sound in your ear? And again, quiet. Oh, yeah, that's gone too. Okay, all right. Does your voice still sound loud in the ear? Oh, that's gone too. And what they mean is they're still got the vestibular stuff, and they're still having that movement sensation where the head's not coordinated with their eye movements. And what I explained to them is, don't worry, that's going to get better. It's going to take a lot longer for your brain to adjust to that. Now it's time to start doing the vestibular rehab therapy.
I like that a lot. That really kind of mirrors a lot of experience that we have with our patients too, and talking about celebrating the small wins and recognizing that things are getting better, but slowly. Going back to surgery, could you talk about some of the risks that patients might face if they undergo surgery for superior canal dehiscence, say?
Sure. So, there's a number of different approaches for treating third mobile window syndrome or superior canal dehiscence. And I can kind of split them up into what I'd call direct and indirect approaches. The indirect approaches are more less invasive, I should say, whereas the direct approaches tend to be more invasive. The way I initially used to treat these folks is I would do a formal middle fossa craniotomy, where we do a craniotomy above the ear, lift up the temporal lobe, and work on it from above. And that entails all the risk of any other craniotomy, stroke, intracranial hemorrhage, meningitis, etc. More recently, I say more recently, probably in the last 15 years, I've gone more kind of a combined transmastoid middle fossa approach, where I still do a little tiny middle fossa craniotomy for some folks, but most of the work is through the mastoid. And the advantage of that is I don't have to manipulate the temporal lobe like I used to do with the middle fossa craniotomy, which I think significantly reduces the risk of brain damage. And it also gets comparable results when you do the surgery. And that's for repairing the superior canal dehiscence. Now, the other thing I would throw out there that you've also got the risk of significant sensory neural hearing loss, as in going deaf in the ear. It's not real common, but if there's just the least amount of inflammation, they can go completely deaf. And I quote patients, it's about a 3% risk of going deaf. Like I said, I've done over 600 of these, and I have about 18 patients who've gone deaf from the procedure. Now, that said, almost to the one, they've told me, Dr. Gianoli, I'm not happy I went deaf, but I am so happy to get rid of the vertigo and dizziness that if you asked me to do it again, I'd do it in a heartbeat. So that's one of the things I think patients have to kind of balance. Is it worth it for that small risk of going deaf in the ear? And if the answer is yes, well, then, that is something to consider. Now the lesser invasive approaches, there's approach called oval and round window reinforcement, where you go in and reinforce the middle ear windows. It's a much less involved approach. It's done straight through the ear canal. You just lift up the eardrum and work on the middle ear, almost like you lift up the hood of a car to work on things underneath. And it's very low risk procedure, much lower risk than the repair of the superior canal. The trade-off being it doesn't have nearly as good a success rate as you do. What I find is the patients that do reasonably well with that are the ones that also get at least some improvement with medical therapy. Obviously the ones that do extremely well with medical therapy, like that 60, 70%, we don't consider surgery at all. So we're talking about just that group that the medical therapy is not enough. The last one I would throw out there is one that it's not traditionally thought of as a treatment for third mobile window syndrome, but I have seen patients who've gotten success with this, especially if they have persistent fullness and pressure in the ear in spite of medical therapy, lymphatic sac decompression surgery. Now, the lymphatic sac surgery was originally devised as a treatment for Meniere's disease, and it's got a fairly good success rate. Meniere's disease, excess of 80% or so. But probably most of the patients that they did this on way back when had third mobile window syndrome. And I've had a couple of patients come in. There's this one guy in particular, I remember, he'd had lymphatic sac surgery, 25 plus years earlier by an older otologist who I knew way back in the day, and got a great result. And he was free of any vertigo, dizziness, Meniere's syndrome for 20 plus years. It all came back. So I work him up, and lo and behold, he's got a superior canal dehiscence. He's got abnormal pressure testing. It's like, well, we need to repair this. And his response to me was, can't you redo that surgery he did back when it worked great? So I did his superior canal dehiscence, but I also revised his sac decompression surgery. So I consider it in some cases where they've got a lot of pressure in their ear, and I think of it as a way to kind of relieve some of the pressure.
I'm sure it's a case by case basis with everything, but is there a general timeline that you look at with how long you're willing to give medical management, lifestyle management a go before saying, okay, I really do recommend surgery in this case?
Yeah, as you mentioned, it's very variable. I think in general, you're going to know within 2 or 3 months whether medical therapy is beneficial or not. I mentioned acetazolamide is one of my favorite medications for this. That there's some downsides to acetazolamide. It's got side effects that some patients find intolerable. And what I do to get around that is I start them off at a very low dose and I gradually increase the dose. And a lot of times you can get patients to tolerate the medication by doing it that way, and their body adjusts to it. The problem with that is it also lengthens out the amount of time that the patients got their disorder. Second becomes, let's say, we're 3 months down the road and the patient still has symptoms. Then it kind of becomes, well, how bad are the symptoms, and is it justifiable to do something more aggressive, such as surgery? And the way I'll explain it to patients is if all the way over on this side, this is flat out miserable, and all the way on this side, this is completely normal. Well, it's relatively easy to take this patient and bring them to here, but it's real hard to bring this patient and bring them to here. So some of these folks that will still have symptoms, I would tell them, I don't know if I can reliably make this any better, with surgery. Is it possible? Yeah, but it's also possible I can make it worse. So, it becomes a discussion with that. Then we have other patients who do extremely well with medical therapy. And there's one that comes to mind who presented with a Meniere's type syndrome. She came in and we put her on the medical management as we talked. This is about 12 years ago. And poof, she was instantly better. Hearing was normal, no vertigo, no dizziness, no pulse out, nothing. I lost track of her after a couple of years. And then 10 years later, she shows up at my office and it's all back. And this time we tried everything again and just could not get control of it. And we wound up repairing her superior canal. And she's been fine since. And I do see that periodically. You just don't know. I mean, the way I think the best way to think of it is the medication and your lifestyle situation, or at least the medication when you take it does the same thing every time. But what's going to change is you and your circumstances. There's a big difference if you gain 40 pounds. I had one patient who was doing extremely well on medical therapy, and then the pandemic hit. And I talked to her a year later just for an annual follow-up, and she said, "Oh my goodness, Dr. Gianoli, everything's gotten back to how it was." And we start talking, and during the pandemic, she's sitting home and she's eating, and she gained 40 pounds. And I said, well, that makes a huge difference on the pressure in your head. And so we really need to up the dose of your medicine. And sure enough, as we brought up the dose, she went back to being in a happy place, if you would. Other patients will develop, kidney problems, other conditions that can cause increased pressure. Probably one of the more common ones is hypothyroidism. So controlling thyroid helps with this as well. Anything you do to reduce the pressure in the head in general is going to help this condition.
I love the way that healthcare is moving, I think, especially post-pandemic, where we really are so much more holistic. And even though your practice involves surgery when it needs to and medical management when it needs to, you're still having that conversation about what the patient can do to empower themselves and take control of their lives and manage their symptoms in ways that don't necessarily involve those things right away. So props to you for that, because I think that's really important in providing quality care these days. Are there any parting words you have for our clinicians, our patients, words of encouragement, research coming out, anything you want to share that you have coming out or already out for our audience?
I think probably the biggest thing I have coming out right now, I'm working on a paper with some French colleagues on basically Meniere's disease and superior canal dehiscence. And, just kind of going through the numbers, there's a society called the Barony Society that has recently taken its charge to set out criteria for diagnosis of different inner ear disorders. And so what we did was we took patients who have superior canal dehiscence syndrome, fulfilling the Barony Society criteria, and then we looked at how many of those patients, number one, have a caloric weakness, as in damage to the inner ear, which is also not highly recognized by my colleagues. And two, how many fulfill the criteria for Meniere's disease. And the kind of the preliminary data we're seeing is about a third will fulfill the criteria for superior canal dehiscence and Meniere's disease. And the take home from that is a cause for Meniere's syndrome, superior canal dehiscence, and other third mobile window disorders. So, I guess the parting words would be, if you have that's something that's very treatable. And frankly, it's one of my favorite patients to see, because I know I can do a lot of good for those folks. One other thing, this is third mobile window syndrome, more specifically, superior canal dehiscence, has been called the great otologic mimicker. And it's mainly because it can present in so many different ways. We talked about some of the characteristic symptoms, but you don't have to have all of them to have the disorder. And sometimes you don't have much of them. And it's because it can present in so many different ways. It can present like patulous eustachian tube, where you have no vestibular symptoms at all. It can present like otosclerosis, where they just have a conductive hearing loss. It can present like Meniere's disease. It can present like vestibular neuritis. It can present like Mal-de-Bartonat syndrome. So once you have a diagnosis, I think you need to have a certain degree of skepticism as to that diagnosis if you're not getting better. If you're getting better, great. But if you're not getting better, you have to question, was the diagnosis right to begin with?
So good. Where can our audience find you?
Sure. Our practice website is www.earandbalance.net. And we've got a number of educational videos on the website, and we have a YouTube channel where I've just started doing some educational videos for patients. Actually, I have one that's in the canister right now for third mobile window syndrome that I haven't edited yet, but I hope to put up soon. But I have I started a little podcast with it, kind of geared toward just educational stuff for patients. It's sort of things I think, well, this is stuff I've been telling patients for the last couple of decades. Let me just put it down on paper. So, it's almost like I don't even have to write a script, because I say it so many times every day.
You can tell you're so knowledgeable and passionate about this. And education is such a major part of empowering this patient population to feel better, faster, get their lives back, and honestly, just give them some hope. So thank you so much, Dr. Gianoli, for joining us on Talk Dizzy to Me. We'll be sure to tag your podcast, your educational series, everything. You're a great resource for our audience. Thank you.
Thank you so much. I appreciate it.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.